Epidermolysis Bullosa by Ashlyn, Jess, Katie, McKenna, and She. This presentation is copyrighted under the Canadian Copyright Act and is for individual use only. Epidermolysis bullosa is a rare genetic skin disorder which causes erosion and blistering of the skin and mucous membranes after minor trauma, such as normal daily movement. The four major types are classified based on which layers of the skin are affected. Epidermolysis bullosa simplex, or EBS, affects the epidermis, more specifically keratin and plectin, as shown in the diagram. Junctional EB affects the lamina lucida, dystrophic EB affects the lamina densa, and kindler EB affects the kindlin-1 protein in the epidermis, but can also affect the lamina lucida and the lamina densa. EBS is the most common type seen, so that's what we'll be focusing on in this presentation. There are three genes most commonly affected in EBS: KRT5, which codes for keratin 5, KRT14, which codes for keratin 14, and PLEC, which codes for plectin. Type 1 keratins are smaller and typically more acidic, while type 2 keratins are larger and typically more basic. Keratin 5 and keratin 14 form heterodimers that make up the cytoskeleton of basal keratinocytes. They provide mechanical protection against physical stress. Plectin's role is to anchor keratin to the plasma membrane. Autosomal dominant subtypes of EBS include Weber-Cockayne, Koebner, Dowling-Meara, and mottled pigmentation. These are most often caused by missense mutations in KRT5 and KRT14, which cause an amino acid substitution. Gene expression of KRT5 and KRT14 does not change, but there's a loss of function. Basal keratinocytes become fragile and prone to rupture and cytolysis, which causes skin lesions and blistering. Autosomal recessive subtypes of EBS include EBS with muscular dystrophy and EBS with pyloric atresia. These are most often caused by nonsense or frameshift mutations in PLEC. Nonsense mutations cause a codon to change to a stop codon, and frameshift mutations cause insertion or deletion of nucleotides that change how the sequence is read. Autosomal dominant subtypes are the most common, so that is what our focus will be on.
So for the mode of inheritance, EBS is usually autosomal dominant, but there have been rare instances of autosomal recessive inheritance. The National Epidermolysis Bullosa Registry in the US estimated that there are roughly 50 cases of EB per 1 million births. 92% of these cases are EBS, 5% are dystrophic, 1% junctional, and 2% unclassified. A study in the Netherlands estimated that roughly 15% of EB patients died, and of those patients who died, 9% of them had the simplex variant, but most of the deaths, about 64%, were caused by junctional EB.
Generally, EBS causes a wide range of fragile skin due to blistering, nail dystrophy, and hyperkeratosis, but leaves little to no scarring. Usually these subtypes of EBS can be distinguishable based on the location of the blister formation. Localized EBS is most common and least severe and can persist from youth to adulthood. The blistering usually occurs mainly through minor trauma, such as the hands and feet, resulting in a thickening of the skin. Koebner causes blistering all over the body, but Dowling-Meara is most severe, as the blistering extends to the oral mucosa of the mouth along with abnormal nail growth. EBS with mottled pigmentation, on the other hand, shows similar symptoms except for blistering in the mouth, with the addition of dark skin pigmentation seen on the limbs and torso of the individual. Because localized EBS is more common and affects approximately 60% of all individuals who have EBS, this slide will discuss the life expectancy of individuals living with this disorder. Blisters usually present at birth and persist throughout their infancy, usually around 12 to 18 months. The blistering eventually decreases as the individual ages and doesn't affect the body systemically. Sometimes the symptoms don't manifest until early adulthood. Depending on the EBS subtype, Most individuals with this disease tend to have a normal life expectancy.
Before any prenatal testing is performed, both parents and any affected offspring are analyzed for pathogenic mutations. For couples at high risk of having a child with EB, chorionic villus sampling can be performed. This can be done as early as 8 to 10 weeks gestation. Fetal skin biopsy was performed commonly in the past, but there are high risks associated with the procedure, as well as a 1% fetal loss, as this would be performed during the second trimester. Chorionic villus sampling, which is done during the first trimester, samples villus trophoblasts, which display immunoreactivity. DNA screening can be performed on amniotic fluid cells and chorionic villi. Preliminary testing for EB begins with a physical exam to assess the skin, as well as a family history check for any known carriers. For confirmatory testing, SNAP frozen or a fresh skin biopsy in Michel's medium must be acquired. The primary method for diagnosis is immunohistochemistry with immunofluorescence mapping. Common antibodies used are anti-keratin 14 and anti-type 4 collagen antibodies, with fluorescent markers. Genetic testing is performed in conjunction with IF to confirm diagnosis. The most common types of sequencing are next-gen or Sanger sequencing. If there is inconclusive immunofluorescence, TEM or transmission electron microscopy is used to look at the ultrastructural appearance of the skin. Because of the lytic nature of EB, hemolysis in wounds are common. A CBC-D, hemoglobin, and other hematological tests can be helpful in monitoring patient status. Patients are more susceptible to bacterial infections, including sepsis, and therefore cultures can be important in patient care.
The main goal of supportive therapy is to prevent further blister formation, which can be achieved by reducing the itching in the patient. Blood transfusions and iron supplements can be used to compensate for blood loss from chronic open wounds in patients with blisters. Antibiotics for new wounds should be used to prevent infection. However, they should be alternated between use to prevent antibiotic-resistant strains of microorganisms from developing. Wound care is especially important to prevent infection and further spread of damage. Nutritional support should also be provided if the condition has spread to their esophagus and they cannot eat whole intact foods. Wounds should be covered to aid in as much healing as possible. Currently, treatments that are available are Apligraf, which is an engineered tissue cultured from neonatal foreskin keratinocytes and fibroblasts shown to heal wounds and prevent further blister formation. Topical steroids can also be used with glutaraldehyde for blister healing. Currently, there are no cures. However, research and clinical trials are in the works for gene therapies, cell-based therapies, recombinant protein therapies, and drug therapies. Some examples of gene therapies are gene replacement, gene editing, RNA-based therapy, and natural gene therapy. Examples of cell-based therapies are fibroblasts, bone marrow transplantation, mesenchymal stromal cells, and induced pluripotential stem cells.